Good day, everyone. Today, we're going to discuss one of the diseases under the inherited bleeding disorders, the hemophilia. The reporters for today's discussion is by yours truly. I am John Vincent Medis Garrote from Section C and Ms. Garrote&Rubenecia from Section E. So our report outline, first, the introduction, prevalence or incident, pathophysiology, treatment algorithm, management, and prognosis. Now, for the definition of hemophilia, hemophilia is a rare bleeding disorder in which the blood doesn't clot in a typical way because it doesn't have enough clotting protein or what we call the clotting factors. Clotting factors are proteins in our blood. They work with our platelets to form blood clots that control bleeding. Low clotting factors increase bleeding risk, which results in an increased risk of bleeding or bruising. Hemophilia can be congenital, inherit, or acquired. Congenital hemophilia is classified by the type of clotting factor that's low. The most common type is hemophilia A, which is associated with a low level of factor VIII. Acquired hemophilia. Some people develop hemophilia with no family history of the disorder. Acquired hemophilia is a variety of the condition that occurs when a person's immune system attacks clotting factor 8 or 9 in the blood. It can be associated with pregnancy, autoimmune conditions, cancer, or drug interactions. Hemophilia inheritance. The most common types of hemophilia, the faulty gene is located on the X chromosome. This means that hemophilia almost always occurs in boys and is passed from mother to son through one of the mother's genes. Most women with a defective gene are carriers who have no signs or symptoms of hemophilia, but some carriers can have bleeding symptoms if their clotting factors are moderately decreased. And now, these types of hemophilia are proteins in our blood that help to stop bleeding and form clots. First is the hemophilia A. It happens when you don't have enough clotting factor 8, also known as the anti-hemophilic factor. Hemophilia B, it happens when you don't have enough clotting factor 9 and also known as the Christmas disease, or this factor known as the plasma thromboplastin component or Christmas factor. The disorder was first reported in the medical literature in 1952 in a patient with the name of Stephen Christmas. The most well-known family with hemophilia B was that of Queen Victoria of England. And lastly is the hemophilia C, or the plasma thromboplastin antecedent, is also known as the clotting factor 11 deficiency. Now for the prevalence or incident, according to the U.S. Centers for Disease Control and Prevention or CDC, in August 2022, about 33,000 people in the U.S. have hemophilia. Hemophilia typically affects men and people assigned male at birth or AMAB. Rarely, women and people assigned female at birth or AFAB or AFAB may have clotting factor levels that are so low that they develop symptoms such as having very heavy periods. Next is more than 200,000 people live with some form of hemophilia worldwide. The condition most commonly affects those who were assigned male at birth. In some study, those assigned female at birth accounted for roughly 18% of mild hemophilia cases and less than 1% severe cases. And lastly, hemophilia typically affects white and Hispanic patients, while it is less prevalent among Black and Asian patients. The pathophysiology of hemophilia. For non-modifiable factors, these are factors that cannot be changed or altered. This includes gender, genetics, autoimmune condition, and family history of hemophilia. For modifiable factors, these are factors that can be changed or managed through lifestyle modifications, treatments, and other interventions. This includes the intensity of treatment, physical activities, and lifestyle modification. Hemophilia is an inherited disorder that caused by a defect in the gene located on the X chromosome that determines how the body may clotting factors 8, 9, or 11. Everyone inherits two sex chromosomes, one from each parent. Females inherit two X chromosomes, one from each parent, and males have a chromosome from the mother and Y chromosome from the father. Since the genetic defect that causes hemophilia is located on X chromosomes, it is passed down from the mother to the son through the mother's gene. This is to say, a male that gets the X chromosome with the altered gene from his mother will have the disorder. Now, down to the flip-tip inversion on X chromosome. This is a type of chromosome rearrangement where a chromosome breaks off and reattaches within the same chromosome. Therefore, we get disruption of factor 8 or factor 9 not produced, meaning it ended up producing reduced amount of factor 8 or factor 9. Therefore, hemophilia is a deficiency of either factor 8 for hemophilia A or factor 9 for hemophilia B. For the delayed bleeding, people with hemophilia may bleed for longer after an injury or surgery because they don't have enough clotting factors. For deep bleeding, people with hemophilia may bleed into deep tissues like our muscles. Spontaneous hemarthrosis, bleeding into a joint without a clear cause, it is the most common musculoskeletal symptom of hemophilia. Now, the vessel constricts. The formation of platelet plug is also known as the primary hemostasis. It is the first step of hemostasis and is the process where a platelet plug forms to prevent further loss of blood from a damaged vessel. It is divided into five stages. First is the endothelial injury. Second, the exposure. Third is the adhesion. Fourth is the activation. And lastly is the aggregation and the fibrin clot. In the fibrin clot, when tissue damage results in bleeding, fibrinogen is converted at the wound into fibrin by the action of thrombin. This is a clotting enzyme. Fibrin molecules then combine to form long fibrin threads that entangle platelets, building up a spongy mass that gradually hardens and contracts to form the blood clot. And the next is the fibrin clot breaks apart. This is due to the lack of clotting factors. Hemophilia A and hemophilia B have the same mechanism. Both are X-linked recessive, meaning it is most predominant in male. For hemophilia A, it is the clotting factor 8 deficiency who have the signs and symptoms of bruising, pain, and swelling, bleeding after surgery or dental work, bleeding in urine or stool, and unexplained irritability. For the hemophilia B, this is the clotting factor 9 deficiency and have the signs and symptoms of bruising, pain, and swelling, bleeding after shots, and vaccine bleeding for infants. Both hemophilia A and hemophilia B increases APTT. This is the activated partial thromboplastin time, meaning if you have an activated partial thromboplastin time or APTT test result indicates that clotting factors is taking longer than normal, which is associated with clotting factor deficiency, liver disease, vitamin K deficiency, and heparin therapy. For the treatment, both hemophilia A and hemophilia B, we have DDAB or the desmopressin. This can help control minor bleeding and prevent bleeding from minor operations. For prophylaxis, we will give this for a severe condition. For factor 8 concentrate, we have the plasma derived, which is made from human plasma pools and recombinant, genetically engineered to not to contain plasma or albumin. and therefore cannot spread bloodborne viruses. And we have another treatment, which is the tranexamic acid. It is an antifibrinolytic agent. It works by blocking the breakdown of blood clots, which prevents bleeding. It's used to treat heavy bleeding. For the diagnosis, consistent bleeding history unless screening for disease in family members with established disease. The APTT is prolonged but corrects with a mixing study, or the APTT may be normal in mild cases. For the mixing studies, this is a blood test that helps determine the cause of an abnormal coagulation test result. Next is the PT or the INR and von Willebrand factor antigen are normal. So, if these three are present, factors levels 8, 9, or 11 are measured to the purpose of to confirm the diagnosis, establish hemophilia type, and classify severity.
I am Rubenecia from BSN 2B. Now let's talk about the treatment algorithm. It is necessary to perform the assessment and know the bleeding history and any family history. As we all know, hemophilia A is a deficiency in factor 8, while the hemophilia B is a deficiency in factor 9. First tip is to identify the type and then the severity of the hemophilia. We have the types of the severity, the mild, moderate, and then the severe. The mild has 5 to 40% of normal factor levels, may have bleeding only after significant trauma or surgery. For the more moderate, it has 1 to 5% of normal levels, result in bleeding after minor trauma or surgery, and can include excessive bleeding or bruising in the joints, muscles, or soft tissues. For the severe, it has less than 1%, leads to spontaneous bleeding, or bleeds for no reasons or without any injury, and requires more aggressive treatment. Understanding the type and then the severity is crucial in determining the both immediate and long-term treatment plans, including whether hospitalization is needed. For the initial evaluation, assessment of bleeding is required. In mild hemophilia A and B, there is a nosebleeds, minor joint bleeds, or bleeding from the gums or mouth. For the moderate and severe cases, there are muscle bleeds, gastrointestinal bleeding, such as vomiting blood or bloody stools, and in severe cases, the central nervous system, which is life-threatening. And with frequent spontaneous bleeds, and bleeds is not responding to home therapy. The laboratory test that will be necessary includes CBC to check for any associated anemia due to blood loss, and then the EPTT test, or activated partial thromboplastin time, as a blood test that measures how long it takes for blood to clot. The prothrombin time, or PT test, the fibrinogen test to measure the amount of fibrinogen in the blood and or how well this protein is helping to form clots, and then the clotting factor test. For the immediate factor replacement therapy, for mild bleeds hemophilia A and B, for factor 8 and 9 is dosed at 20 to 40 international unit per kilogram. This dose this dose helps to stop smaller bleeds like those in joints or small muscle bleeds. Typically, these bleeds can be managed at home unless they do not involve with treatment or complications arise. For the hemophilia A, for the moderate or severe bleeds, example of CNS or gastrointestinal bleeding, higher doses is required, up to 40 to 100 IU per kilogram. In these cases, hospitalization is often necessary, especially for the life-threatening bleeds like those in the brain or abdomen.
For moderate to severe bleeding, in hemophilia B, 50 to 100 IU per kilogram is needed. Hospitalization is typically required for severe bleeding or cases involving the CNS or gastrointestinal tract. In management of recurrent or chronic bleeding, for the patient with mild hemophilia, we have adjunctive therapies. Desmopressin or DDAVP is used in mild hemophilia A. This small percent can be used to stimulate the release of stored factor VIII. It is particularly useful for mild bleeding or before minor procedures. Antifibrinolytics like tranexamic acids are often given for mucosal bleeding, example of nosebleeds or dental extractions, to help prevent clot breakdown. And the rise, which means rest, ice, compression, and elevation. Joint bleeds are common in hemophilia and rise as a supportive treatment along with factor infusions. Patients with severe hemophilia often need prophylactic treatment to prevent spontaneous bleeding episodes, which can cause joint damage over time.
In hemophilia A, factor VIII is administered 2 to 3 times weekly, and for the hemophilia B, factor IX is administered 1 to 2 times weekly. This regular dosing helps keep factor level high enough to prevent spontaneous bleeds. Hospitalizations is not usually needed for routine prophylaxis, as patient or caregivers are trained to infuse factors at home. For the management of inhibitors, some patients develop antibodies to factor VIII or IX, making standard treatment ineffective. These patients need alternative therapies. Immune tolerance inductions or ITI. This therapy is used to train the immune system to stop production inhibitors. ITI is typically done in specialized centers, often requiring hospitalization during the initiation phase. And in the bypassing agent, if inhibitors are present, bypassing agents like recombinant activated factor 7 are used to promote clotting, and then the hospitalization may be needed. In surgical or dental procedures, for the pre-surgical planning, hemophilia patients require special precautions before any surgery or dental procedures. Factor levels are optimized to prevent excessive bleeding. Hospitalization is necessary for major surgeries, but minor procedures like dental work can sometimes be done without patient management using prophylactic factor replacement and antifibrinolytics. For the post-operative care, after surgeries, patient may need extended factor replacement and monitoring, which may require hospitalization, particularly in complex or invasive procedures. In long-term management and follow-up, we have routine monitoring, factor level, joint assessment, and screening for inhibitors is necessary. Routine care and physiotherapy can generally be done in outpatient settings. Hospitalization is required for major bleeds, life-threatening situations, surgical interventions, or if inhibitors complicate treatment. Home management with factor infusions is possible for minor bleeds and prophylaxis. Regular follow-up is essential to prevent complications, with hospitalization reserved for emergencies or complex cases. So, if the symptoms suggest bleeding, treatment should begin immediately, even before the diagnostic tests are completed. For example, the treatment for headache that might indicate intracranial hemorrhage should begin before the CT scan is completed. Let's go now for the treatment of the hemophilia. First, we have the replacement of the deficient factor. Factor VIII can be given as purified plasma-derived factor VIII concentrate, which is derived from the multiple donors. It then undergoes viral inactivations, but inactivation may not be eliminate parvovirus or hepatitis A virus. Recombinant factor VIII is free for viruses and is usually preferred. In hemophilia B, factor IX can be given as purified or recombinant viral inactivated product every 12 to 24 hours. The target levels of the factor corrections are the same as the hemophilia A. However, to achieve this level, the dose must be higher than in hemophilia A because factor IX is smaller than factor VIII and contrast to factor VIII. Has extensive intravascular distribution. Each unit per kilogram of factor IX increases the factor IX level by 1%. Due to intravascular distribution, the initial dose of factor IX is generally 25% higher than subsequent doses. Next, we have fresh frozen plasma. Contains factor VIII and factor IX. However, unless plasma exchange is done, sufficient whole plasma usually cannot be given to the patient with severe hemophilia to raise factor VIII or factor IX to level that prevent or control bleeding. Fresh frozen plasma should therefore be used only if factor concentrates are not available. Cryoprecipitate contains factor VIII and can be used as a replacement product if factor VIII concentrates are not available. Each unit of cryoprecipitate contains 80 units of factor VIII. Because plasma and cryoprecipitate are generally not virally inactivated, this blood product should be used only in emergencies when factor concentrates are not available. For hemophilia A, imicizumab is a humanized monoclonal antibody directed to factor IXA and factor 10. When restores missing factor VIIIa functions in the kinase complex in patient with hemophilia A, allowing for thrombin generations and restoring hemostasis. Imicizumab is administered as a subcutaneous injections every 1, 2, or 4 weeks, and it has a half-life of 28 days. Therapeutic agents in clinical trials for both hemophilia A and B includes the fitusiran and the concizumab. Fitusiran is a small inhibitory RNA that knocks down the production of the natural anticoagulation protein antithrombin. Concizumab is a humanized monoclonal antibody that blocks tissue factor pathways inhibitor, or the TFPI, another natural anticoagulation protein, and increases thrombin production in hemophilia A and B. Next, we have gene therapy for hemophilia A. It's a one-time infusion that uses a vector to deliver an functional gene to replace the hemophilia patient's own defective gene or a therapeutic gene to provide a missing protein. The result is better clotting factor activity, which protects against bleeding. Adjunctive therapy for mild hemophilia A may therefore include in vivo stimulation of patient endothelial cells with the synthetic vasopressin analog DDAVP or diaminodearnidine vasopressin, or also known as desmopressin. Desmopressin may temporarily raise factor VIII levels. The patient response should be tested before desmopressin is used therapeutically. It is used after minor trauma or before elective dental surgery may obviate the need for replacement therapy. Next is we have antifibrinolytic agent. Aminocapiubic acid or tranexamic acid may also be used as adjunctive therapy in hemophilia A or V to suppress fibrinolysis and prevent late bleeding after dental extractions or other oropharyngeal mucosal trauma, example of tongue lacerations. For the nursing management, first we have to do is to help the patient cope with their condition, support patient emotionally and mentally by providing information about the hemophilia, reducing anxiety, and helping them adapt to lifestyle changes. Encourage participation in support groups and connect them with resources to foster resilience and positive coping mechanism. Patient and family caregiver training. Teach patient and caregivers how to administer factor concentrates at home, ensuring they understand proper storage, preparations, and injection techniques to manage bleeding episodes promptly and safely. Education on activity restrictions and self-care strategies. Educate about the safe physical activities to prevent injuries and emphasize self-care strategies like maintaining a healthy weight, avoiding risky sports, and recognizing early signs of bleeding.
Prophylactic factor replacement. Encourage regular prophylactic treatment with clotting factor concentrate to prevent spontaneous bleeding and joint damage, improving long-term health outcomes. For the oral hygiene, promote proper dental care, including gentle brushing and regular checkups to prevent gum bleeding while avoiding invasive dental procedures. Avoid certain medications and procedures. Instruct patient to avoid aspirin, NSAIDs, supplements, and alcohol as they increase bleeding risk. Refrain from nasal packing for epistasis and any invasive procedures without consulting a specialist. And then during the bleeding, assess and monitor. Carefully evaluate the site and severity of bleeding, noting any signs of increased swelling, bruising, or difficulty in mobility.
Pain management. Administer appropriate analgesics, avoiding NSAIDs to manage significant pain associated with bleeding episodes. Warm bath or heat avoidance. Recommend warm baths for muscle relaxations but avoid the direct heat application, which can worsen the bleeding. Last is the genetic testing and counseling. Advise patient and families to undergo genetic testing to identify carriers and understand inheritance patterns and plans future pregnancies with informed choices. The life expectancy of patients with hemophilia depends on whether they receive appropriate treatment. With appropriate treatment, their life expectancy is only about 10 years shorter than that of healthy men. The high rate of death before the adulthood is due to inadequate treatment. Life expectancy also depends on whether the patient has other medical diseases. The mortality rate of patients with hemophilia is twice that of healthy men, and the mortality rate of those with severe hemophilia is 4 to 6 times higher. The life expectancy of people with hemophilia was short before the scientists developed factor concentrates. A spike in the hemophilia mortality rate in the 1980s was due to hepatitis and human immunodeficiency virus or HIV infection associated with therapy.